Okay, hello everyone. Again, my name is Valentina Rabin, and I'm a Doctor of Audiology student at LSU I have the privilege of introducing Dr. Shannon Cooper-Sadlo. Dr. Cooper-Sadlo is a graduate of the University of Denver Master of Social Work program and obtained her PhD in family therapy from St. Louis University. She is an associate clinical professor of social work at St. Louis University. Her area of study is with women and family who have experienced incarceration and other family separation. She teaches clinical courses in both the Bachelor's of Science of Social Work and Master of Social Work program. She has been in clinical practice with various populations for over 20 years and specializes in areas of couples and family therapy, substance abuse, co-occurring disorders, anxiety, and depression. Take it away, Dr. Cooper-Sadlo.
Hello, it's good to be seen. I'm going to preface all of this by saying that I am not a Zoom expert, and so if something happens, it always happens for me. So I'm gonna do my best. And the other thing is I'm at home and it's always quiet until I get on a Zoom call. And so if you hear a dog barking, if you see a boy wandering about, I really did try to keep that from happening. So I'm very grateful that I was asked to present to you all today from a social work perspective about what is happening with our communities of color, with what is happening with our communities in the rural areas where perhaps our the healthcare systems are not as effective as they are in the urban areas. And really looking at what's been happening from a trauma-informed perspective and a social work perspective. So what I was hoping to do is just kind of give a little background and then open it up for questions. I sometimes tend to find that to be more interesting when you're doing kind of a short presentation rather than being able to get into everything at the level if this were longer. So first and foremost, I think what's important for us to remember is that aside from the mental health issues that have become more prominent, have become more obvious due to COVID, and I know you had another speaker who's talking directly about that, is that this idea of what we call collective trauma. And at this point, it's global trauma in looking at how has COVID-19, how has what's been the result of COVID-19 negatively impacted all of us, but especially our more vulnerable populations who were already experiencing the trauma of poverty, the trauma of oppression and racism, the trauma of health inequities. And so when we think about how this has created a population that is not only suffering, as we all are experiencing difficulties with COVID, that it's added an extra layer of trauma to their experiences. And so when we think about kind of health inequity in the United States, we know that a lot of our disenfranchised populations have been hit harder and have experienced more negative consequences and have less support and less ability to bounce back from those hits. And so really thinking about how this impacts perhaps the clients that we work with of what was kind of on a normal day, short-term thinking, which we know is a byproduct of traumatized communities, is that they don't have the privilege of long-term planning. And so they very often are living on a day-to-day basis, making decisions that are in their best interest for today, and how difficult that can be, especially when from a global perspective, from a country perspective, we have no idea when this is going to end. we have no idea the depths of destruction that are going to happen. And so really recognizing that a lot of our clients that are going to be seeking services are going to experience more anxiety, are going to experience more depression, are going to have more severe consequences than our communities of privilege, who do have access to healthcare, who have that financial safety net if there is a job loss, who have the ability to take care of their children if schools are not allowed to go to come back in session. And so really thinking about what the ripple effect is onto our already vulnerable populations. So I wanted to just at this point see if there are any questions that are coming up with just kind of the beginning piece of this. Anybody has if anything's come up in questions?
Not yet.
Okay, so when we continue to think about kind of the racial inequality that goes along with kind of what's happening in the world right now, and in our country especially right now, is that our vulnerable populations are people of color, our communities of color. What we already know is that they are experiencing the consequences of COVID at a higher rate and having more dire consequences. And a lot of that is based in the fact that the populations have already, they started at a kind of, I always think about it as a race, and they were already starting the race further back than communities of privilege. And so when you add on to kind of this idea of collective trauma, when you add on all of these other stressors, we start to see, and I think it becomes much more apparent to the community at large, what are those inequities and how much of it is based in racial inequality. And I think that's something that has really come to light in the past 6 months, is the difference in quality healthcare, the difference in insurance availability and coverage. What are those educational resources and support for children in at-risk communities? Where is the safe housing? How are families, and it may be that we have multi-generational families living together. One person gets sick. How do we talk about quarantining so that we are protecting other vulnerable members of the population, of the household? And so from a social work perspective, as we know, is that we have to look at this as person and environment as a whole systemic issue, and not just looking at it from a person, an experience that one person is having. We know a lot about the socioeconomic inequality. And again, with COVID, I think that has become more visible. I think it's always been there, but it was easier to ignore it. And now when we're looking at going back to school, we're looking at, that's, we see it in the news a lot about going back to school and why it's so important for kids to go back to school. And I think we tend to look at, or we tend to hear about it from a place of privilege of, well, the children need to be, they need to have their social experiences and it's bad for their mental health. And we're not looking at it from what does it mean for a single parent if school is not in session? What does it mean if that single parent gets sick? What does it mean if that child gets sick? What are the consequences of that? We know that there's been an uptick in intimate partner violence. We know that there's been an uptick in child abuse situations because of the close living quarters, because of the added stress that families are experiencing due to job loss, due to the fact that the kids are at home. And if I've got, small kids, I can't leave them at home. And that's negatively impacting my ability to work. It may be that we're experiencing more job loss. And especially when we're talking about single family homes who really depend on their children going to school for their nutrition, to be able to have healthy lunches. And so I think a lot of this has really come up, and we are now having to pay attention to something that most of us who are in the field have been aware of for a very long time, that our school systems are much more than education systems. They are oftentimes the anchor that keeps families afloat, and when that is gone, we really recognize how much that adds to a burden of an already burdened family, and that stressful environment. So where do we go from here? As social workers, we have really embraced this idea of having a trauma-informed response to most everything, is that we look at things through a trauma-informed lens, and that we really need to understand what are some of the emotional responses that our clients may be having. We need to recognize the negative impacts that COVID and the ramifications of COVID are having on our already overstressed and traumatized populations. That we really need to look at how do we help folks in the long term, and that as a community with collective trauma, we don't know how to sometimes address anything in the long term, but there are going to be long-term consequences for what's been happening for 2020. And so we really need to recognize what are going to be those long-term issues, and how are we going to address them, instead of kind of holding our families accountable for, or holding them in a way that we're looking at the rest of the population, rather than looking at them from folks who have already experienced significant trauma. What is the importance of those supportive relationships, and what are the resources that people are going to need in order to address some of these long-term consequences? We have a lot of families who, before the pandemic, were hanging on, were able to make it. They were hanging on by a thread, but they were making it. And now we're looking at a lot of these families that's gone. And so, how do we help to rebuild that from a longer term perspective? We also need to look at how are we providing mental health treatment for our families? How are we providing support for our families? Are we ensuring that it's culturally sensitive? Are we taking that into account? That when we are working with families who are in communities of color, that their experiences are going to be very different, and their needs may be different than kind of what we think about when we think about research that tends to be with a white population, and addressing the needs from a white population perspective, is that really looking at what is it about this particular culture that they have needs that are going to be different. When we look at families that are primarily led by women, as single parent homes, what does that impact? Because we know that women have different needs. And so how are we building our programming? How are we building those supports around the needs of our clients as they are, rather than kind of on the stereotypical family process? We need to ensure that we are maintaining safety. Always has to be our first response, especially when we are talking about people who've experienced trauma. We know that Trauma comes out of that feeling of being out of control. A lot of those responses that we look at tend to be fight or flight. And so we have people who are not making good long-term decisions because they are in that state of fight or flight. And so really being able to think about how do we create a sense of safety for our clients so that they can think about things in a way that is going to provide long-term stability. How are we engaging the community to help members of the community so that we're not the outside person coming in and dictating or telling them what they need to do, but how are we capitalizing on the strength of the community and what are those community resources, and are we supporting what is already available to that community? And that it needs to be very collaborative. Again, it's not us coming in and imposing what we think is the right thing to do, as much as it's a conversation with the community of what is it that they need, and being open to thinking about that different communities are going to need different things based on what are the resources that are available. So at this point, I just, again, I'll open it up to any questions that may be available.
Would you rather have all the questions at the end at our Q&A?
I mean, we can start the Q&A right now because that's kind of all I have as far as a PowerPoint, and so I just wanted to kind of start the conversation and then and allow for questions, and that can guide our conversation to a more specific place.
Sure. Okay. So our first question is, how has your work as a social worker changed, if any, with a mostly virtual world now?
It's been a little bit more difficult, and especially when you talk about understanding context of people's experience. And so when you are on telehealth, first of all, you are making some assumptions that people have that capacity. And I think that's something as social workers that we take for granted, that we really need to recognize that a lot of our families really struggle with just access to the internet, good internet, that have access to personal computers or iPhones or smartphones. And so that to me has been one of the bigger issues, is making sure that people have access, and in that access, do they have a sense of safety? So if I don't have, Wi-Fi in my house, or I don't have a computer, then I have to go to somebody else's, I have to go to a library, I have to go somewhere where I'm again putting myself at risk, maybe putting my family at risk because I have to go out in public. And so I think with the telehealth, while in some ways, if it's available and people are able to utilize it, it is a way to keep people safe. But I also think that we make assumptions, and that's obviously coming from our place of privilege, and in that assumption that people have access to what we have access to. Some of it is just being able to have a quiet space. I know, as I said in the beginning, I struggle with finding a quiet space in my house to be able to do a Zoom meeting or to be able to do class. And that if you are living in a small apartment and you've got, numerous people there, it can interfere with the ability to be honest about what's going on, to really be able to ask for what you need, for being able to have that sense of privacy with your care provider. So those have been the issues that I've experienced. I've talked to other therapists who have said similar things, but also have said that in some ways the access has been better, because if they have those things available to them, maybe they're not having to get on the bus, maybe they're not having to find childcare. Some of the other issues that have come up with barriers to access previously, maybe that telehealth has been really helpful. And so I think what we can learn from this as we've experienced this is that telehealth may need to be an option going forward. and that we may not need to completely revert back to in-person interaction completely, but adding that to for our clients who maybe struggle with some of our barriers. And what we know is that one of the reasons that people don't participate in treatment is because of transportation. And so if we are including telehealth as part of that, part of our process and part of our options for our clients, that we may actually be able to reach more people. So I don't know if that answers the question. It was kind of a long and rambling answer.
Great. The next question is, as a future healthcare provider, what do you recommend as highlights that we should take away from your presentation when providing a trauma-informed response to our patients?
I think the first thing is really going to be about your worldview and how are you approaching this? And so if you are truly approaching it from a trauma-informed perspective, there's a different level of understanding or empathy for our client's experience. And so what I mean by that is that if I'm coming from the lens of your behavior is perfectly rational and normal considering the context that it's coming out of. And so that makes a difference of how I approach. Instead of saying, oh, well, this person, and I hear this a lot with, so young caregiver, people who are young in the field, they're saying, well, they just are resistant. They just don't want to do this. They just, they're not ready to change, all of those types of things. But when we come from a trauma-informed perspective, we recognize that clients, their behaviors make sense in the context of what's happening. And so then our job is really to understand the behavior. And so how is it a response to whatever is happening in their lives? And so, if we have a client, I think about the increase in substance use. I think about the increase in drug use. I think about the increase in disordered eating, not eating disorders, but, people putting on weight. And, maybe if somebody has an issue with food to begin with, whether it's diabetes or high blood pressure, and they're not doing what we say they should do, and they're not following the diet that we say that they should follow, and why don't they care about this, is recognizing that food may be their only comfort at this point. That may be the only thing that they have any level of control over. And so when we come from a trauma-informed perspective, we start to recognize what is the purpose of those behaviors that is attempting to create normalcy and a sense of control, that when people are in traumatic experiences, that's what they're grasping at. And so that's what I mean by looking at it from why are they doing what they're doing and what purpose does it serve? And that helps me to better address the situation. So I hope that answers your question.
Okay, the next question is, what guidance do you have for professionals from other disciplines in terms of responding to the populations you talked about? I guess that's similar to the question you just answered. Add or should I can go to the next one?
Okay.
Okay, so the next one is, have you seen an increase in foster homes and shelters because of COVID? How have you seen the educational change within those environments?
So, I don't know exactly about. There hasn't been a lot of research, I guess, because it's still so new. And so looking at it, but it would make sense that as the rates of child abuse and neglect increase, that we're going to look at more foster homes. We already don't have enough foster homes. We already don't have enough people to care for our children who are in the care division of family services. And so I think people are already hesitant to take in kids. And with everything that's going on, I think we're likely going to see an increase in the number of kids who are going to end up in group homes or in other situations rather than being able to find foster care for the kids. And and with the educational piece, I'm not, I don't know. I think that that's going to be something that we see more from a long-term situation of how did going online impact learning. How did it impact kids who were already in situations where schools were underfunded, where schools didn't have access to a lot of the resources? How much further behind are they? And I think that's going to be something that is going to be an area of interest as we start to come out of this, and we kind of do that retrospection of, okay, here's the result of what happened when we have mandates for children to be learning online and not maybe completely understanding what that means within the context of that child's home. What does that look like if they are left at home to take care of, younger siblings so that parents can go work? How much are they actually being able to engage in that learning process? And then at least if they were at school, they wouldn't be taking care of younger children. And so I think that's just a really complicated, intertwined situation that I think when we come out of this, or as we're coming out of it, we're gonna be surprised at what's happened.
Can you talk a little bit about how incarcerated populations have been affected, and any recommendations on how to prevent or slow the spread in incarcerated populations or ICE camps?
So, and I think we've seen this, and it absolutely makes sense based on how the virus is spread. And this is not just incarcerated, kind of in our typical jail settings, but also in which this is a population that I think is often forgotten about, is our population that are in forensic hospitals or in long-term care hospitals, psychiatric hospitals. Is that anytime there's community living, there's going to be spread. I think that we have absolutely seen that. I think, and I'm trying not to say this in a way that is political, I guess, but I have a strong belief that people don't need to be incarcerated for nonviolent offenses if they just simply because they can't pay bail. So I think we need to really look at kind of this idea of cash bail. And so are we just bringing people into already this community that is, things are going to spread. Even when we weren't talking about COVID, illness spreads around in jails and facilities. And it's something especially as this virus, and you think about, what we're learning now about the ventilation systems and all of those types of things. Our jails do not have those. Our schools don't have those. There's no way that our jails are going to have those. And so part of it is releasing people who don't need to be there, and not incarcerating people who don't need to be there. And so really thinking about how are we trying to manage the folks who are there. Once you're talking about a long-term incarceration, I think we have to look at the people they are coming in contact with, and how much are we trying to control that, the virus spread with the staff, and who's coming in, and what are the precautions that we are requiring of the people who are taking care of the people who are incarcerated. And so I think a mix of all of those things needs to be considered. The problem with folks who are incarcerated is that as a society, we see them as less than human, and so we're not really that concerned about it. And what we need to really be thinking about is that this is also a population that leaves incarceration and goes back to their family, goes back to their community, and can also contribute to the spread of the virus in some of our more vulnerable communities and with our more vulnerable populations. But as a community, we don't really care. We don't really think too much about what's happening with them while they're there, which I think is that's a bigger social justice issue in itself.
Considering that telehealth is the new way that psychiatric or psychotherapeutic care is utilizing to provide care, have you seen a marginalization of certain populations due to limited technological access? And how have various organizations tried to combat this discrepancy?
And as I said before, I absolutely believe that there are populations that now have no access to facilities. I know that in our desire to make sure that our social workers and our caregivers are safe by closing down the facilities or closing down, the day programs or, any of those types of things where people routinely got some of their mental health care needs met. I think that we have a number of people who are really, really struggling, not even just with access, but we also have to remember that some of our folks who are suffering with severe and persistent mental illness, that this whole thing can really feed into their already fragile mental health state. So, I think about some of the clients' reactions who maybe have a long-term history of schizophrenia and who may already have some experiencing symptoms that include paranoia about technology and, all of those types of things. And that this is happening to them. And a lot of times we don't think about kind of the impact on some of our folks with severe and persistent mental illness. And I've kind of gotten away from what the question was, but yes, I do believe that there is a part of our population who they're not receiving any assistance or assistance to the level that they were before the pandemic and the level of assistance that they need. And so again, that does become an access issue. I think that as social workers, it's hard to balance, but we have to balance the health and care of our caregivers with the health and care of our clients. And so trying to figure out what that looks like and how can we provide access to things that we take for granted, or we've got to be creative. And a lot of times that's not something that we are, we like to follow rules. We do what we're supposed to do. And we sometimes have to think outside of our typical service providing in order to reach people who are at most at risk of us kind of losing.
We have another question. It says, as a medical student, I don't have much experience with social work in the outpatient setting. When would you consult social work to help a patient you are concerned about?
Immediately. So if you are identifying that the client has a lack of social supports, has a lack of available resources, family support, any of those things, is not waiting until the last minute, when they're getting ready to discharge, to try to connect people to social services. Social services, unfortunately, I think as most of us know, are terribly underfunded. And so sometimes it's harder to get people into services as quickly as they need to be. And so that's why I always say, if you even have a question about this person needing resources outside of a hospital setting, is that from day one, the social worker is working on getting those outpatient needs met. I think we're finally figuring out that we lose a lot of people from hospitalization to outpatient care. And so we're starting to see pilot programs that are coming out. And I was talking with a colleague who works with a local mental health center where they just got a grant where they are actually having social workers come in and do assessments in the ER or on the psych unit for intimate partner violence and for suicidality, so that there is a connection from the crisis to when somebody can get into services, and that there is a contact person, there is somebody who's checking in and making sure that people aren't falling through the cracks in these really kind of dangerous situations. And so I think we're figuring out that if we want to stop the long-term really negative consequences, that we got to start at that crisis point and provide those services immediately and continuously until they can get into that outpatient long-term care for whatever it is.
Okay, we have time for one quick question. So
Okay.
for people with less resources on mental health, are there any free resources available now? You know?
I think that there are a number of free resources. So in the community, contacting behavioral health response, and I know that this is a national, people are coming in from all over the place, is that looking for those crisis services is a way to get somebody in, and they tend to act as a safety net until there is the ability to find long-term care. I think if you look at your bigger community mental health centers, is that people are figuring out that we have to provide services to people, whether they have insurance or not, and that's usually the quickest way. And that at least here in St. Louis, there are a number of our bigger our bigger centers that actually have what they're calling like a crisis unit, where people are able to get those walk-in services and they're not being charged. And so whether it's because they're grant funded or they're funded by the state, so they are out there, and that's, to me, the best way to figure out where to go is to call those centers. Somebody said the United Way often has a list of people who are providing, who will provide either low cost or no cost mental health services.
Well, thank you, Dr. Cooper-Sadlo, for sharing this information. Just as a reminder to everyone else, if you have any further questions, submit them to the Q&A box and we'll answer them during the full panel Q&A at the end of the conference. Now we're going to take a short break. Thank you again.
Thank you.